And instead of having 3 presentations, we have 2. And my colleagues will talk a little bit about those 2 sessions. And because they have 2 posters, we shall not take questions. We shall go outside and do the questions at the posters. I agree with you that it's going to be very tight. I will introduce them all at the same time so that we don't waste time. The first speaker is my colleague, Sharon Warren. She's a research scientist at Pop Council. She has had many years of experience, and she'll be tackling a topic called measuring integration using index. The second speaker is Obure, a research fellow at the London School of Tropical Medicine, and she will be looking at the measuring resource efficiency within the cost-effectiveness. And with those few remarks, I would really want to take this opportunity to welcome Warren to make her presentation. Thank you.
Thank you for those remarks. Thank you all for being here. I'm presenting this on behalf of the Integra Initiative, and includes my colleagues from the London School of Hygiene and Tropical Medicine and Abuya. So this is looking at how we can measure service integration over time and using a multi-dimensional index. And it's a continuing story of measurement challenges and innovation. So as you all know by now, the Integra Initiative is a quasi-experimental intervention evaluation, and we're working in 42 facilities in Kenya and Swaziland. And these challenges, the challenges of the research that are embedded in real programs, i.e. the program science approach, affect the integration impact analysis. Because we heard earlier that some of the comparison facilities were kind of integrated as well as the intervention facilities because of other inputs from other people, or as in Kenya where integration is a national strategy. So to try and address this, the Integra Initiative developed an index model that we call the Continuum Integrated Care Index. So as those who were here earlier, there are 4 models. We'll be using 3 at this point. So looking at integrating HIV, STI, HIV care and survival cancer screening into family planning, then the HIV services into postnatal care and family planning, and then the 3rd model is integrated HIV and SOH services, which is in the IPPF clinics. So just to show you the timeline of the data collection activities and the breadth of the data collection, we did the community survey in 2009. We did a costing baseline during 2009-2010, and again just recently. We did health facility assessments over the last 4 years. We also did plan flow time series analysis, which was recording every person who came into the facility during 1 week, what services they accessed. Then the cohort time series that we recently just presented on. So you can see, and then in addition to all of this, we have qualitative data to look at other issues in more detail. So nothing is what it seems. So the real setting, the comparison facilitators were contaminated by, as I said earlier, by additional activities on integration or by staff actions at individual facilities. There's one facility in Swaziland who, just by the fact that we were asking questions about integration, they decided to go ahead and do their own integration, which I think is messes up our analysis. There were lots of issues within implementation of the actual intervention. Depending on how motivated people were to make the changes or to change the way they worked, to integrate, there were problems with stockouts. We had people that were trained on integration or mentored, and then they moved on to another facility. So the degree of integration achieved and sustained at individual clinics has varied and changed over time. And the women that we interviewed at one specific facility that you heard earlier, on family planning clinics or the postnatal clinics, did not necessarily stay at those facilities, and they'd gone somewhere else, and it could have been a comparison site. So these are some of the issues that we have to take into consideration. So what is the solution? How do we measure and account for the actual degree of integration in each facility over time? So we need to look at a range of clinic-specific data that is available at different time points to then construct a multi-dimensional index to measure the continuum of achieved integration. So this multi-dimensional index, we have 4 dimensions of the index, which we based on literature, and then we defined 8 indicators needed to capture these dimensions. And we use the clinic data on each attribute to generate attribute scores for each clinic. And then once we've done that with the data, we then have expert input on the attributes and ask people to, researchers and health providers and other senior technical people, to rank what they thought the attributes should be. And then we did some latent variable modeling to determine weighting of attributes in association with integration. And this analysis was used to give each clinic an integration score on a continuum derived from the 8 individual attribute scores. So these were used in the outcome, or would be used to monitor the changes in integration, to control for initial levels of integration that we took at a baseline, or to associate the level of integration with the outcomes. So in building the index of integration, so the first I mentioned was physical integration, which meant that the service availability within the MCHFP, the physical resources available, and the location of the ART clinics and referral. And you can see on the right-hand side, the data source was the periodic activity review, costing data, and client flow tool. I won't go into the detail, it's also replicated on the post-track side. So then we have what we call temporal integration, which was the range of services available daily and the range of services accessed daily. And again, we use client flow tool and the periodic activity review. And then provider integration, which was from the costing data registers about the percent of services that are provided per clinical staff member in a day. And then functional integration, which is true to the range of services accessed, the range of services provided, and the range of services provided in one visit. So we looked at the percent of days in a week on which components of integration are accessed, and among those times receiving any service, the percent who received an index service plus one other, and then the percent who received an index service plus another SRH service during their visit to the facility. So these are facilities in Kenya, and you can see that the first column is facility, then the availability in MCH FP units, the range of services available daily, and you can see that in some facilities in Eastern Province, which is the PMC area, were not able, didn't have such a high service range of services. Then the range of service access daily, human nuclear staff integration, room integration, range of services provided in consultation, and range of services provided in one visit. So the consultation is in one room and the visit is in the one facility. So what is associated with integration? So you see that the range of services available daily and the range of services accessed daily findings. And then for the actual facilities, per facility, we saw that the ranking, that there was broad agreement between the data and the experts in ranking. So we think that the scores and the ranking produced by the model are reliable. The clinic scores are a weighted composite from the model. It's the experts' evaluation of attributes plus the data alone, and experts' direct ranking are an average of the ranking each clinic got. The data is more highly weighted than the experts' ranking because of the many clinics, and the number of experts ranking is small. The fact that low scores are represented in most integrations is a function of us scoring the expert in the exercise, where the most integrated facility is ranked at 1, so the data scores follow suit. So the best can kind of consider this as a continuum. So you can see that those facilities were the highest integrated services. So for the next steps, we will use this tool again to describe how the clinics are changing over time in terms of the central service integration and then the changes across the types of facility and attributes of facilities, and also to compare the difference between the intervention and outcome. So we also need to identify the characteristics most closely associated with integration in the different contexts, and also to use it to look at the impact of integration to enable attribution of particular health and service outcomes to the of service integration, and to help determine cut-off points beyond which integrated services are no longer cost efficient for good quality. Thank you to the team.
As you can see, looking at integration, cost and effectiveness is not easy. You have to take into account the total time and have a critical look at the data.
Thank you. Good afternoon, everyone. I'll be presenting on behalf of my colleagues of the London School of Hygiene and Tropical Medicine some results of the economic evaluation of integrated HIV and sexual reproductive health services in Kenya and Swaziland. And I'll begin my presentation with a brief background on the economics around integrating HIV and sexual reproductive health services and looking at how integration is expected to influence the cost of service delivery. And as we all know, integration of HIV and SRH services aims to improve the delivery of both HIV and sexual reproductive health services, and this is particularly through improved coverage of services. And while there is some evidence of the health and social benefits of integration of these services, which actually supports further efforts to integrate within the sphere of service delivery, we find that there is scarce high-quality economic evidence underpinning integration of these services, with very few studies on costs and efficiency of integrating HIV and sexual reproductive health services. So, looking at how integration is expected to influence the cost of HIV and sexual reproductive services, from an economics perspective, integration is actually expected to yield efficiency gains through two main ways. The first is through economies of scale, which we define as the cost savings that result from an increase in output levels. So in this case, the cost savings that will result from an increase in the number of services provided and the number of clients that are accessing these services. And secondly, efficiency gains can be achieved through economies of scope, which imply reduction in cost of production of services from expansion of a number of different output types, which is associated with input sharing of shared overheads as well as specialized staff and equipment. So looking at the framework for economic analysis, we conducted a cost study at baseline in 2008-2009 in 41 health facilities in Kenya and Swaziland, so 30 in Kenya and 11 in Swaziland. And we did a full cost analysis from a health provider perspective, which means that we excluded the costs that a client, receives from accessing the services. And we looked at different input components, particularly capital, which included building, equipment, as well as staff training, and also looked at the recurrent costs such as personnel salaries, drugs, diagnostics, and supplies across the different facilities. And the activities that we costed were sexual reproductive health services, which included family planning, postnatal care, cervical cancer screening, as well as HIV services such as HIV counseling and testing, STI management, and HIV treatment and care. The results that we're presenting today are actually looking at comparing integrated HIV counseling and testing, which is provided through a PITC model, particularly looking at HIV counseling and testing provided within the context of a FP and a postnatal visit, compared to standalone services which are provided within VCT centers. And our main measure of technical efficiency, which implies the relationship between the inputs and the outputs, is the unit cost per client visit, which looks specifically at the staff time, the space, and the overheads. We do not include the cost of supplies and diagnostics because this is not likely to change with any integration process. And to look at the staff time, we did a time in motion study whereby we were able to sit with the service providers to ascertain the amount of time they spent on each of the health activities that they were providing and to be able to allocate their costs across the different services. And some results, when we look at the cost of integrated HIV counseling and testing compared to VCT services in Swaziland, you can see from the graph that the blue represents the PITC services and the red represents the VCT services. We find that across the different facilities in Swaziland, that standalone HTC actually compares favorably compared to integrated HTC in 3 of the facility types. However, in the large hospital, we found higher costs for standalone HTC services, so through VCT. But overall, when we look at the costs, we see that PITC compares favorably at about $8 per client cancelled and tested, compared to VCT at $9 per client cancelled and tested. And in terms of the cost per client diagnosed HIV positive, we see a slightly lower cost per client diagnosed HIV positive in the VCT settings compared to the PITC setting. And this is largely because a large number of the clients who are testing positive are testing through VCT compared to the PITC model. And in Kenya, we see a different picture, and consistently we find across the different health facilities that PITC is comparing favorably to VCT services, with an average cost per client cancelled and tested at about just under $6 compared to $8 for standalone HCT services. And however, unlike in Swaziland, the cost per client diagnosed HIV positive in VCT is higher at $110 compared to $47 in PITC. And in this context, PITC is more effective in identifying HIV positive clients compared to the Swazi context. And so, looking at the variation in the unit cost, we decided to look at what exactly is driving the unit cost across the different services. And this graph just shows the different types of inputs. It's a breakdown of the cost by the different input types in Kenya. And we see from the graph that the blue parts of the bars represent salary costs. And we see that salary costs actually make up a significant proportion of unit costs for both the non-integrated and integrated HCT services, accounting for about 30 to 95%. Capital costs, which are represented by the red, are actually significantly low in all the health facilities, and the capital costs include cost of equipment, which is very good for HCT, as well as the cost of staff training. And the other cost looks at the cost of recurrent cost of building maintenance, and it's relatively high in some of the health facilities. And looking at the same breakdown in Swaziland, again we see a similar picture with very few exceptions across the two different approaches for HIV counseling and testing. We see that staff salary costs are the main cost driver, accounting for the significant proportion of total costs across all the services. And so what are the main areas of efficiency gained from integration? And as we've seen from the two graphs that looked at what the breakdown by input type, we see that unit cost per client is driven by the cost of human resources. So, however, we found very little variation in salary costs across the two countries, including the staff types that we use, so clinical staff or HIV counseling and testing counselor across the different facilities within each country. So to explain the variation in the cost of personnel costs, we looked at staff workload as well as the intensity of use of capital resources. And this graph here just looks at the variation in staff workload across the integral projects in Kenya and Swaziland. And looking at this for both VCT and PITC services, we can see from the slide that PITC actually achieves more number of client visits per staff full-time equivalents in a day across both countries, with very few exceptions. Then when we look at the variation in capital resources across the integral project facilities, again we see variations across the different countries and across the different facilities, with space being utilized by up to 2 client visits per square meter per day. And this variation actually shows that there's room for improvement across all the health facilities. So just quickly a summary of the findings. We see that from our results we can see that there is scope for integration to improve efficiency of SRH and HIV interventions, particularly by increasing the numbers of clients and facilitating more efficient use of staff and capital resources. But a simple reading of these results would suggest that policymakers should actually prioritize PITC, so integrated HIV counseling and testing, in all settings, given the low unit cost per visit seen for these services. However, this would be incorrect, as our results suggest that other factors as well drive efficiency of services. And these factors include HIV prevalence, hence demand for the services that are being provided, and staffing issues, and all these are context specific. Furthermore, when we look at integrated HIV counseling and testing services and standalone VCT services, they are not substitutes for each other in all settings. We find that different clientele attends VCT services, particularly men mostly, and PITCs within their maternal and child health units is usually attended by women. So when planning the delivery of HIV counseling and testing services, we propose that one should not only take into account the cost of the service, but also the effectiveness and the desirability of the services from a client's perspective. And where demand is low, thought should be placed on ways of either better locating the standalone services or adding more services to VCT settings so that these settings are used and staff are used effectively. But again, we should be careful not to expand integrated services into settings that are already overstretched unless there's additional staffing that can be made available. So the next steps in terms of the economic evaluation are, we have just completed the final round of costing, and we'll be looking at an analysis of this cost to determine changes in unit cost per visit and human and capital resource utilization that results from integration, and then be able to better explain the variations in costs of different services. And we'll also be using non-parametric data envelopment analysis to estimate the technical efficiency of health facilities, as well as incorporating the quality of care measures, because it's a little bit dangerous to look at just the cost side of things without looking at the quality of service that is being provided. And we'll also be using the index of integration that Charlotte has just presented on to account for the degree of integration at each facility level in an econometric analysis to determine the impact of integration on the costs and efficiency of HIV and SRH services. I'd like to acknowledge the Ministries of Health in Kenya and Swaziland, Family Health Options Kenya, Family Life Association of Swaziland, and the Bill and Melinda Gates. candidates for funding for this project. Thank you.
Thank you, Carol. Thank you, Warren. Dear participants, I'm really in a big dilemma. As I said in the beginning, this is a very, very important topic that was really given very little time, and I have been warned I'm over my time by 5 minutes. And my colleagues will be outside in the poster room, and I'm sure they'll be willing to take a few questions. I think I have no choice but to close the session and thank Carol and Warren for a very good effort, but for a work in progress. As you can see, these cost issues, you have to be very careful talking about what they mean. And I want to take this opportunity to thank them again, and please let's give them a clap. And you can see there were 2 strong women, no men, that done a very good job, and thank you for listening. Thank you.